I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
A 34-year-old woman with a self-palpated stage 1 invasive mucinous carcinoma of the right breast. This is a T1b node negative, ERPR positive, HER2 negative, grade 1, with an Oncotype score of 16, underwent mastectomy with negative margins and sentinel lymph node biopsy. She is very anxious about additional treatment, specifically very reticent for chemotherapy or radiation. And so what is the role of adjuvant therapy for a very young woman with atypical histology in this situation with the mucinous carcinoma, but with the sort of conflicting elevated Ki-67 of 34%, early stage breast cancer with a low Oncotype score. So Dr. Pegram, do you want to comment about what you make of this invasive mucinous carcinoma with an Oncotype score of 16, but this sort of elevated Ki-67?
You know, the pure mucinous carcinomas do have a more favorable prognosis as compared to infiltrating ductal carcinoma not otherwise specified. Indeed, it's said that a 1 centimeter mucinous, a 3 centimeter mucinous carcinoma has the same prognosis as a 1 centimeter infiltrating ductal not otherwise specified node negative case. So right off the bat, based on histology alone, I would say that she has a more favorable prognosis. The Ki-67 of 34% is pretty much inconsistent with a mucinous, a pure mucinous histology. So I'd want to go over the pathology in a tumor board situation and look at the sample and make sure it's not an infiltrating carcinoma with mucinous features as opposed to pure mucinous. Now the Ki-67, also you'd want to actually see these slides because the Ki-67 fraction can vary considerably across the face of a tumor section, particularly around the edges of the tumor. It may often be higher where it's closer to the vascular supply and less intense in the center sections of the tumor section. So I would want to get a handle on what that 37% actually means and what the standard deviations are around that 34% in this case. Could this actually be, reconsidered if you looked at other areas of the tumor as a Ki-67 something less? And this 34 might have been a representative of the viable tumor on the exterior surface next to the vascular supply, and therefore it was high, but overall our prognosis may still be good. That said, it's important to consider that if you're going to use endocrine therapy alone in this case, which I would, if it's pure mucinous, is that in the adjuvant trials of ovarian function suppression with AI, the results were particularly good in the age range under age 35, which this patient fits into that category. So I would think instead of chemotherapy in this case, you could offer the more aggressive ovarian function suppression plus AI option as a pure endocrine therapy option, since she may not benefit from chemotherapy given the recurrence score and the results from the soft and text trials in the young patient population could improve the outcome with ovarian function suppression and AI as compared to tamoxifen alone.
Okay, thank you. So importantly here, review of pathology, really confirmation of that pure mucinous histology, kind of critical in how you think about this patient.
Exactly.
Okay, great. So our next, yes, please.
And can I just make, sorry, thank you. You mentioned that she was BRCA1 and 2 negative, but I would just encourage that in young women like this, that we should be doing broader panel testing, at least for the top 9 most common mutations. So that could be considered as well.
Of course. Thank you so much. I appreciate that insight, especially for these, as you mentioned, these very young patients. So important.